Assalamu alaikum. We will begin with musculoskeletal system today in special pathology. And musculoskeletal system, I had one lecture with you before in which we discussed the normal architecture, orchestra of the bone, the cells of the bone, how they make and break the bone, and the the rhythm between them. So today we will discuss metabolic bone diseases, out of which osteoporosis was discussed to some extent even before. And today we will do it, we'll complete the topic. Renal osteodystrophy, osteomalacia, rickets, hyperparathyroidism, and osteopetrosis are new to you. All right, so osteoporosis, although a little boring, but it is the common most disease of today, and it is the one which leads to several other osteoid problems, bone fractures, and uh, osteoarthritis, etc. So, what I want you to learn today is that the way it, I'll just go through this quickly because we have discussed most of it before. So bone turnover is because of osteoclasts, blasts, and osteocytes. I told you before that osteocytes and blasts have got one nucleus, although osteoblasts are larger than the osteocytes, and osteoclasts are multinucleated cells that are actually bone macrophages and are meant for dissolving the bone. Osteoclast, what it does is the bone resorption. Osteoblast makes the bone, and osteocytes are small cells that sit, they are mature osteoblasts that sit into the Hessian system. So, osteoporosis, what is it? Disease characterized by reduced bone mass, causing bone to become pretty much porous. So, and that predisposes to fracture, and the disorder may be localized to some regions of the bone more than the generalized skeleton. And then we discussed that there is something called primary osteoporosis, and then there is something called secondary osteoporosis. From primary, or when we talk about the primary osteoporosis, we talk about post-menopausal, senile, and idiopathic osteoporosis. Whereas secondary osteoporosis has got several causes, including endocrine, including gastrointestinal, and neoplasias. Right. So endocrine has got hyperparathyroidism, hyperthyroidism, hypothyroidism, and hypogonadism, pituitary tumors, diabetes type 1, and Addison's disease. And the secondary osteoporosis, gastrointestinal causes will be malnutrition, malabsorption, anything that will not let vitamin D and calcium to get absorbed will get osteoporosis. Hepatic insufficiency, all of these are metabolic diseases, vitamin C and D deficiencies. Neoplasias, uh, multiple myeloma is a plasma cell neoplasia that actually makes the bone very much porous. And then carcinomatosis. Carcinomatosis is the spread of a cancer into the bone. Miscellaneous osteogenesis imperfecta, immobilization, which means hospitalized patients who are unable to walk, CVA patients who are immobilized have to have some physiotherapies just because otherwise they bone dissolution and the bone resorption causing osteoporosis. Pulmonary diseases, homocystinuria, anemia, drugs, I told you, anticoagulants, anticonvulsants, and alcohols. They are the common drugs. Chemotherapy and corticosteroids are the other drugs. Three drugs begin with A and finish. These are the secondary causes of secondary osteoporosis, just a picture so that can stimulate your memory more. Pathogenesis, age, osteoblast of elderly have reduced proliferative and biosynthetic potential. proteins bound to extracellular matrix such as bone factors lose their biological effectiveness and decrease physical activity. So osteoblasts have reduced capability of proliferating, and extracellular matrix such as growth factors lose their biological effectiveness. It is like things are leaving your side. Decreased physical activity that contributes to bone pains and osteoarthritis. This is a normal bone. Look at the number of small pores and number of very large pores that are in osteoporosis that result in osteoporosis. So there has to be mechanical stimulation of the bones to keep them healthy. Bone density is higher in athletics, like load lifting will increase the bone density because muscle contraction is more effective stimuli for increasing bone mass and jogging. Bone loss occurs as in an immobilized or paralyzed extremity. There is reduced skeletal mass in astronauts and in zero gravity environment for prolonged periods. So if there is no gravity, people are more likely to get osteoporosis. Calcium nutritional states. If the calcium does not meet the demand of growing bone, the young people will also get osteoporosis. Adolescent girls are more than adolescent boys, so adolescent girls tend to develop osteoporosis because of insufficient calcium intake during the period of rapid bone growth, increased parathyroid hormone concentration, and reduced level of vitamin D. Hormonal influences in the decade after menopause, yearly reduction in the bone mass may reach up to 2% of the cortical bone and 9% of the cancellous bone. Women may lose up to 35% of their cortical bone and 50% of their trabecular bone within 13 to 40 years after menopause. The postmenopausal women suffer from osteoporotic fractures more commonly than the men of the same age because of withdrawal effect of hormones is more in female than in males. So females suffer from osteoporosis far earlier than men. Postmenopausal osteoporosis is caused by estrogen deficiency. Or why is it caused with estrogen deficiency? Because estrogen acts to increase the bone mass. And how does the estrogen increase the bone mass? The cytokines stimulate osteoclast recruitment activity by increasing rankle while diminishing the expression of OPG. So rankle is the receptors, the ligand receptors, and osteoprotein is the expression of the disease stimulant. Compensatory osteoblastic activity occurs, which does not keep pace, leading to high turnover from osteoporosis. And the same comes in as menopause, decreased serum estrogen, increased interleukin 1, 6, and human-protein factor, increased expression of rank and rankle, which is receptor activated nuclear factor kappa B and uh, uh, receptor activated nuclear factor kappa B ligand. Increased osteoclastic activity occurs, aging, there is decreased synthetic activity from osteoblast, decreased replicative activity of osteoprogenitor cells, and decreased biological activity of matrix bound growth factors. And then there is also reduced physical activity. Primary osteoporosis, and there's several other secondary osteoporosis in which the entire skeleton is affected. But few bones may tend to get affected more than the others. In postmenopausal osteoporosis, increased osteoclast activity mainly uh, for the bone portions that have increased surface area is more active, such as cancellous components of vertical bodies. So you can see the osteoporotic bone here, which has got very large pores. So the trabecular plates become perforated, thinned, and lose their interconnections, leading to progressive microfractures eventually. Perhaps. Microfractures are something that may not get detected on the X-ray, but actually they are very painful because they are fractures. And they will eventually result in bone marrow prolapse, the bone prolapse or the vertebral prolapse. Look at this osteoporosis, thin bone. In senile osteoporosis, the cortex is thinned by subperiosteal and endosteal resorption, and the Versian system is widened. In severe cases, Versian systems are so enlarged that cortex mimics cancellous bone. The bone that remains is of normal composition. Clinical manifestations, these depend on involved. That means where the pain begins or which area of the bone is affected earlier than the other bones, such as the spine gets affected for the rest of the bone. So the person will get back pain and will, may get hunchback fibrosis. Most frequently affected bones are thoracic and lumbar vertebrae. These become painful and tender when multiple vertebrae are involved, and these cause loss of weight and deformities, including lumbar kyphosis and kyphosis. Progressive loss of height. We always talk of elderly as no matter tall people are said to lose their height as they age. This is a clinical picture of a female that has got full-blown osteoporosis. This is a traditional picture. They would call it a traditional picture. Look at her back, elderly woman with curved back, stoop posture, a woman this bust height, and appears small and frail. Now, this is a typical picture, and of course, ask her how much pain she's got in her and how difficult for her, or how difficult it is for her to. So sometimes we talk of a person who fell down and broke his hip joint. And we talk of, I don't know if she fell down or if he fell down before there was a hip fracture or there was a hip fracture before she fell down or he fell down or the person fell down before and then developed a fracture. So the most probable theory is that people get fracture before they fall down. However, the neck of the femur is so fragile that even a minor trauma or a small trauma can cause a fracture. The same goes for the people who are on bed for a very long time. They develop pathological fracture with their limb, or you can say with their foot falling outwards, and that does not happen with the normal people. The foot does not fall outwards or laterally. And secondly, the limb that is fractured gets shortened because of contraction of the muscles of that limb. Look at this hip fracture, right? One limb is shorter than the other, and you can see the neck of the femur getting fractured. And you must be knowing by your anatomy knowledge that the head of the femur is supplied by the artery, gluteal artery, going from down below. So the head is going to get decreased. Clinical results of osteoporotic fracture is pain, reduction in the physical activity, deformity, muscle weakness, social isolation, loss of independence, and increased mortality. Special radiological imaging techniques, dual X-ray, energy X-ray, and bone density. Histopathological studies that comes one and bone refined biopsy. They are rarely done for seeing or diagnosing osteoporosis. Otherwise, bone density is the best modality. X-rays show osteoporosis after more than 50% of bone has been lost. So bone density is more sensitive than normal X-ray. Right. These are some of the pictures how the bone density is being done. These are called as Texas scans. We come on the second pathology, which is renal osteodystrophy. You must understand that the renal osteodystrophy also displays itself. It is the pathology is more as the time passes, and secondly, the severity of the disease. Renal osteodystrophy is seen with advanced renal diseases, which I was trying to make you understand that every time there is a secondary pathology, it is always observed after long time has passed and the disease has all its uh, peak, or you can say it has become fully manifest. Clinical presentation is bone pain, most common presentations, spontaneous fractures, aseptic necrosis of hip, and myopathy. Myopathy, there is a lot of muscle pain and that accompanies the bone pain. Spontaneous fracture because renal osteodystrophy also develops, patients with renal develop osteoporosis. And then there is aseptic necrosis of hyperphosphatemia, low levels of vitamin D, which is 125 hydroxycholecalciferol, alteration in the secretion of parathyroid hormone. X-ray subperiosteal erosion is there, patchy osteonecrosis, which is rugged jersey, appearance of thoracic vertebral spine or laterally, salt and pepper, appearance of the skull is there, and then there is lift appearance. Renal osteodystrophy X-ray, subperiosteal erosions are there. Right. So you can see the subperiosteal erosions in the picture, and look at this T-shirt. Patchy osteosclerosis, rugged jersey, appearance of thoracic vertebral spine on the lateral. Just look at the T-shirt. And there are dark and light areas in the T-shirt, and now look at the spine. There are dark and light areas in the spine. This is what is rugged jersey, patchy osteosclerosis, appearance of the thoracic spine. This is the lateral X-ray. Now, if you note, the skull X-ray has got multiple hypotenuse areas or something like stippling, and this is called as salt and pepper appearance of the skull. This appearance is shared by several other diseases like multiple myeloma. It has written about salt and pepper appearance. Hypoparathyroidism and problems with the parathyroid hormone does present in the same way. So it is though not pathognomic, but it is present in this disease. If we talk of the third metabolic disease called osteomalacia, it is bone softening because of defective bone mineralization. That means you will have lot of osteome with no mineralization of the bone. So defective mineralization of trabecular and cortical bone matrix. There is associated decreased serum calcium phosphate, a common complication of chronic renal failure in adults, right? And then secondary to the vitamin D deficiency. So just osteomalacia is secondary to so many things. If vitamin D is absent, if there is renal failure, if there is decreased calcium in the bone, and what it results is always defective calcification of the bone matrix. So you can see expanded, excessive quantities of osteome or osteoid. This is large amount of osteoid that is marked, and because of failed matrix calcification, despite continuous matrix synthesis by the osteoclast. We come on the disease called rickets. You have studied that in previous classes, and although the terms are heard of by you, but still I will elaborate them a lot more. Growth plate is vital, right? Growth plate is vital and irregular columnar rearrangement of hypertrophic chondrocytes is lost. Zone of provisional calcification disappears. Cartilage extends deep into the metaphyses. This might seem a little difficult to remember, but there is a. Let's look at the picture. Growth plate is vital. You can see the normal versus the vital growth plate in the picture. Columnar rearrangement of hypertrophic chondrocytes is lost. That is on microscopic appearance. Zone of provisional calcification is microscopic, but cartilage extends deep into the metaphysis. You can see it right there. Cartilage is going deep into the metaphysis, right? Such a haphazard cartilage is there. Now, this is the normal bone. We talked about zone of provisional calcification that disappears. Just look at the calcified zone marked with blue. This is zone of provisional calcification marked blue. This gets lost. This is a normal bone, and look at the rickettsial bone. Calcification zone is shown again, and this area is lost. Pictures show the same histological picture of the same. Metabolic bone disease rickets has got clinical features of craniotables. All of the terms are heard of before, but we will just elaborate in a single slide what they mean. Craniotables, frontal bossing, ricketic rossi, pectus excavatum, Harrison's groove, thoracic kyphosis, and ricketic pot belly. Craniotables. This is the cranium. And craniotables, just look at the baby and remember, put in the finger in the bone and just go on inside the skull or inside the cranium of this baby. Soft thinning of the skull in the infants and children. It is seen mostly in the occipital and parietal bones. They're big bones. The bones are soft when pressure is applied and they will collapse. This is what is happening. They will collapse. Gone inside of the pressure of one. This is cranial. Frontal bossing. Look at the protrusion. Frontal plates in this little child. It is prominent, protruding forehead that's also often associated with heavy bow ridges. Frontal bossing. Ricketic bruising. You have heard the word before. Refers to expansion of anterior rib ends at the costochondral junctions. Look at the costochondral junctions. They're so much visible and even now. Most frequently seen as rickets as nodularity at the costochondral junction. You can see that very Pectus excavatum. Look at the vacuum in the chest. Nothing has to be said. You just see there is an abnormality. Chest has gone inside. The sternum is going inside. Pectus excavatum in Latin means hollowed chest. In this deformity, several ribs and the sternum grow inwards. This produces a caved or sunken appearance of the chest. Harrison's groove, also known as Harrison's sulcus, it is horizontal groove along the lower border of the thorax. It corresponds to the costal insertion of the diaphragm, which means even the diaphragm has reduced or left a mark on the chest wall. It is usually caused by chronic asthma or obstructive respiratory diseases. Chronic asthma, from where do these things come? Chronic asthma, obstructive respiratory diseases. We're talking about the bone deformities caused by the rickets. Well, that is very simple to think that the Chronic asthma, obstructive respiratory diseases, they cause a lot of stress on the chest wall. They pull in the chest wall and they leave a groove mark there that is also called as Harrison's groove or Harrison's sulcus. And because the bones are very soft in liquids, so they produce the same groove, and that is called as the Harrison's sulcus. Look at the ricketic pot belly, a large round stomach that sticks out. It is called as the ricketic pot belly. Genuvulgum, another term, genuvulgum. You have heard it several times. If you make a boy stand or you make a suppress stand, he cannot get his two legs straight. This is also called as knock-knee. It is a condition in which knee angle in and touch one another when the legs are straightened. Individuals with severe valgus deformity are typically unable to touch their feet together. So, since their knee joints meet together, their feet don't meet together, and there is a distance between their feet. Typically unable to touch their feet together, right? While simultaneously straightening. So this is what is vulgum and this is what is verum. These are two opposite terms. In verum, feet come together, but the knees are quite distant apart. So what we're dealing with is the vulgum gene. All the normalities are now put together in a single child, and you have to remember every word just in this way. Make a rough sketch by your own hand and draw these things on that little child or the sculpture you draw. So you will every time open your that page that on which you have drawn this thing, you will remember a lot of things. Hyperparathyroidism, the metabolic, last metabolic problem is hyperparathyroidism. Skeletal manifestations are caused by osteoclastic bone resorption, entire skeleton, which means not a single bone, the whole skeleton. The osteitis fibrosa cystica, rare nowadays, but it does exist, and so the term does exist as well. This is what is osteitis fibrosa cystica, osteitis, inflammation, fibrosis, and cyst formation, a condition that is associated with hyperparathyroidism and it is pathetic, in which bone tissue becomes soft and deformed. Treatment is directed towards underlying parathyroid condition and removing any resected rib. This is what you see here. This is actually a picture of a rib. Uh, that rib is also called as having Brown's tumor near the costal. Same picture. Morphology. Primary hyperparathyroidism causes osteoclastic, raised osteoclastic activity, cortical, affecting cortical bone more severely than the casus bone, which means the cortical bone is the harder part of the bone, the outer and the harder part of the bone. And if it affects the outer and harder part of the bone, it strikes the harder part of the bone more severely, then it will become very thin. Secondary hyperparathyroidism skeleton abnormalities are milder, but the primary are stronger. Dissecting osteitis, another term. Look at the bone broken in pieces, and there is a tract inside. This is dissecting osteitis. Osteoclast tunnel into clast is meant for breaking the bone, so they break the bone. So osteoclast tunnel into and dissect centrally along the length of the trapecular, creating a railroad. It has created a road appearance of a railroad track. So it has created a way, a railroad track. X-ray involved, what does it show? Middle phalanx and involved radial aspect of the middle phalanx of the index and middle finger. We just look at the hypodense area in the middle phalanx. It is marked for you, the hypodense areas are marked. Bone loss predisposes to microfractures again and secondary hemorrhages that causes influx of multinucleated macrophages in growth of fibrous tissue, creating a mass of reactive tissue. You see a lot of fibrous tissue and large macrophages in microgram, right? So you see a large amount of macrophages and you see fibrous tissue. And the same or nearly the same picture is there in the giant cell tumor of the bone. But the giant cell tumor of the bone is not the same as Brown's tumor because the giant cell tumor of the bone has got may have it may have nuclei up to 100 and more, but this one has got lesser. However, we do have you can think of differential in the case of picture you might can have might can think of a differential. Osteopetrosis. Osteopetrosis is a marble bone, inherited lysosomal defect. In most severe forms, it can be lethal, and death secondary to anemia, cranial nerve entrapments, and hydrocephalus, and because of infections. It is also known as marble bone disease, Albert Schoenberg disease, dense bone weighs far more than the normal, even double or triple the weight of a normal. Treatment is bone marrow therapy and interferon. So we end up with metabolic disease of the bone. Now it is the second topic. Second topic is bone infections. It is very common in the general population. Just think of a bone infection in someone who's playing football or might have a open wound and the bone might catch infection because of the surrounding unhygienic conditions. So bone infections are quite common in the general population and so there's a common question of examinations. So we've got pyogenic bone infections and we've got tuberculosis, which is specific bone infection, and we've got syphilitic disease. So we have got pyogenic osteomyelitis, syphilitic osteomyelitis. So what is the difference between the two? Osteomyelitis, common causative organisms, contributors, fed complications, and common sites involved in tuberculosis osteomyelitis. Osteomyelitis, infection, inflammation of the bone and that is how you define inflammation. Inflammation can be septic and it can be septic. So we have heard of aseptic necrosis. And now we're talking about the organisms. So inflammation of the bones is the primary area where we are going to focus. Is actually the organisms that have caused our bone to get inflamed. Complications, it may be there may be a complication of any systemic infection, right? If there is infection elsewhere, the bone may get infected because of mutagens. Frequently manifest as primary or serotype focus of disease. Organisms could be virus, parasites, fungi, bacteria can produce osteomyelitis. Common organisms are pyogenic bacteria and pyogenic osteomyelitis. So it spreads by three ways. Metagenous as another area is infected and the bone might get infection. Extension from a contagious site, wound may be there, or direct implantation from a wound or from a so all what I want to say is that please do sports in practice if there is a malignancy that wound is a weak area and this weak area has got far more tendency to catch infections than the normal wound. So Beware that there is malignancy in the base that may be your primary source of infection, of causing fever and other symptoms of septicemia, and that may lead the patient to short stay. Frequently isolated patients with genitourinary tract infections or with intravenous drug abuse. Intravenous drug abusers seem to use the reused syringes and many dirty intravenous tubes. Don't care how to manage it. So E. coli, Klebsiella, and Pseudomonas are common in these cases. Direct surgery or open practice, mixed bacterial infections. Sickle cell people, yes, sickle cell patients develop salmonella. Salmonella, right? Sickle cell patients will develop salmonella infections for unknown reasons. 50% of the cases have site of involvement influenced by the vascular circulation, which varies with the age. So, in neonates, children, and adults, separate areas are more prone to develop infections. In neonates, metaphyseal vessels penetrate in the growth plate, resulting in frequent infection of metaphysis, epiphysis, or in children it is metaphysis. In adults, it is epiphysis and subchondral regions. Stages designated on clinical duration of disease. It can be acute, subacute, or chronic. Sequence of infection, necrosis of the bone within first 48 hours. Necrosis of the bone within first 48 hours. Necrosis. It is because the bone is hard and when the pressure builds inside the bone, there are more places for the infection to come out and it will cause necrosis of the bone. We percolate through the Wilson system to reach the periosteum. So it will cause periosteal formation. In children, periosteum is loosely attached to the cortex. A sizable subperiosteal abscess formation because the periosteum is given way a huge collection of pus may gather there and cause a huge collection of abscess. Whereas in the adults, that is not the case. The process happens in first 48 hours. Once localized in the bone, bacteria proliferate rapidly. They love such an unhealthy and induce acute inflammatory reaction cause cell death. That is there. So it is just sources of infection going in, rheumatogenic root disseminated from osteomyelitis, spread from adjacent of tissue, and diagnostic or therapeutic measures and penetrating damage or trauma. Further, ischemia and bone necrosis occurs. Necrosis, osteonecrosis. Uh, Let me tell you. Once the bone manages, when the infection manages to kill the bone, or it may cause osteonecrosis, the dead portion of the bone is called as the sequestrum. That is called as the sequestrum, and that dead portion or dying portion always initiates a reaction around the normal bone, and that causes some new bone formation. And this new bone formation or new bone is involution. So sequestrum is the dead bone that is that portion of the bone caused by the osteonecrosis, and sequestrum and involution is the live bone that is caused by the secondary new bone formation. Sequestrum is, as you see in the picture, all pink area. You don't see anything in this pink area. There is no formed element. You don't see any cell. This is just pink. This is dead tissue. It is a dead. So involution after the first week, chronic inflammatory cells become more numerous and they release cytokines. The result is in deposition of new bone formation at the periphery. New bone may be deposited as a sleeve of living tissue known as involution. So osteomyelitis, this is the gross appearance as marked, and this is the microscopic appearance. You see very hypercellular vessels. If you see through higher magnification of microscope, you just realize they are all inflammatory cells. Acute inflammatory cells in case of acute inflammation and chronic inflammation. So in the Lutheran newborn is deposited like that. Brody's abscess. It is a small intraosseous abscess that frequently involves cortex and is wall of reactive bone. And then there is another term, sclerosing osteomyelitis of Berry, typically develops in the jaw. Brody's abscess. This is how the bone infection occurs in a small bone. Small intraosseous abscess. It is a small tumor, intraosseous abscess that frequently involves cortex and is walled off by the reactive bone. So it is a small abscess in the bone. Right. Sclerosing osteomyelitis of Erie typically develops in the jaw. This is osteomyelitis of Erie. Clinical course is fever, chills, malaise, marked to intense throbbing pain over the affected region. Diagnosis. Signs and symptoms you can diagnose by the X-ray. First is the sign. First, the patient will come to you might have an exterior wound that communicates with the exterior that will help you diagnose. You can take the X-ray, blood cultures will show you which organism is positive, and rarely a biopsy is done or necessary. Otherwise, all the rest of the departments will let you know the diagnosis of osteomyelitis. Clench fist osteomyelitis. Can you clench his fist? Is what can you clench his fist? This badly swollen hand, and there is, I'm sure, a lot of pain there. And look at the index finger on the knuckle. You can see some hidden abscess. So it is osteomyelitis because the wound is actually communicating with the exterior and there is some infection. Young child, osteomyelitis of the tibia. Numerous abscesses of the bone show as radiolucence. Looks like a fracture, but it is osteomyelitis. Diabetic patient who previously underwent a transmetatarsal amputation and shows infection. These are other dental images of abscess. Generalized advanced horizontal periodontal neurons. Can you see that radiolucent area below the root with very apical radiolucency? That is a panoramic X-ray shown. Panoramic X-ray is the name of this X-ray shown osteomyelitis. Sketch the affected area. So plain radiograph showing osteomyelitis of the second metatarsal arrow and periosteal elevation of cortical disruption and medullary interplaces. Treatment. This is, I think, very much a good combination of antibiotics. Surgical drainage is the usual curative tool. Do you know why do we have to surgically drain these abscesses? We're given antibiotic choices. Our culture and sensitivity. Why do we have to drain these abscesses? It's because all abscesses, does not particularly all abscesses have got no blood supply inside of penetrating abscess. Blood vessels will penetrate the abscess. So you drain the abscess so the blood vessels can take the antibiotic to the remaining area of infection and will actually cure or will actually be recycled for that area and will cure the area. And if there is a large abscess sitting there, there is no blood supply. Complications, pathological fractures, secondary myelinosis, endocarditis because the infection will spread to the blood and cause septicemia, the infection will circulate through the body. So endocarditis, if previously the patient has got pelvic and sepsis, squamous cell carcinoma, rarely sarcoma in affected bone. Please note here squamous cell carcinoma in affected bone. Tuberculosis osteomyelitis. Tuberculosis osteomyelitis. I just want to share this experience of mine. In a ward that has got a patient with tuberculosis osteomyelitis, rolls in pain, and it is a very painful condition. Child or adult, whoever is the patient, will not like to speak to the physician anymore. Just want to give them terrible. Blood-borne disease originates from focus of active visceral disease, direct extension, for example, from a pulmonary focus into a rib or from tracheobronchial nodes into chest vertebra, or seeding via draining lymphatics. So the lymphatics will take the infection to the bone, or the blood will take the infection to the bone. There may be a primary focus in the lung or elsewhere. Patient with AIDS, they have got deficient immunity. They are more prone to this tuberculosis osteoarthritis. Most common sites of skeletal involvement are thoracic, lumbar, vertebral, horse disease. Whenever there is involvement of the spine, particularly thoracic and lumbar spine, whenever there is involvement of the spine by the tuberculosis, it is called as horse disease. Horse disease is involvement of the spine. Skeletal tuberculosis. Tuberculosis osteomyelitis involves mainly the thoracic and lumbar spine. Like horse disease, followed by knee and then knee before the leg. So infection breaks through the intervertebral disc and extends into the soft tissue forming abscesses. Intervertebral discs are tough tissues, but it breaks away the tough tissue of the intervertebral disc. And then it goes out in the soft tissues, that is the muscles around the bone. So it involves all the muscles as well. There is extensive necrosis, bone destruction, compression fractures with kyphosis and extension to soft tissues, including psoas muscle, and that is what is called as the bone abscess. So the osteomyelitis of the bone can be because of tuberculosis, or osteomyelitis because of tuberculosis, maybe because of the lung or gastrointestinal tract. Most commonly, vertebral bodies can be long bones. Once established, bacteria provoke chronic inflammatory reactions. Small patches of caseous necrosis are formed and they will become abscesses, and the abscesses are called as cold abscesses. The infection spreads across the epiphysis joints, and the inflammation may track along the soft tissues to appear as cold abscess at a distant site. Source abscess in case of spinal tuberculosis. This is the MRI of the spine, spinal tuberculosis, and you can see involvement of T10, T11, and you can see the disc spaces, narrowing disc spaces, adjacent multi-loculated paravertebral abscesses. This is abdomen showing the left iliopsoas abscess. Arrow is marked that is likely originated from tuberculous osteomyelitis involving T12, L1, and L2. Clinical features: pain, fever, weight loss. They may form an inguinal mark which represent as cold fluctuant psoas abscess, bone destruction, tuberculous arthritis, sinus tract formation, and myelinosis. Myelinosis is always there in a chronic condition. Then comes syphilitic osteoarthritis. So I think syphilitic osteoarthritis is the last of it. The, the transplacental spread of spirochetes from mother to fetus results in congenital syphilis. Long wounds such as tibia may affect. So congenital syphilis has got two forms: periostitis and osteochondritis. Congenital syphilis has got periostitis and osteochondritis. Regarding acquired syphilis, bone lesions are manifestations of tertiary syphilis. Gummus lesion appear as discrete, punched out radial lesions in the medulla or destructive lesions in the cortex. Surrounding bone is sclerotic and non-discharge is present. Bone comes in, skeletal bone comes in whenever there is tertiary syphilis, not primary syphilis, and that is called as gummatous lesion. Gummatous lesion. And what is this gummatous lesion that involves the bone? Punched out radiolucent lesions. Gummatous lesions are punched out radiolucent lesions in the medulla, or these are destructive lesions. Whenever the word destructive lesion comes, we usually take it as malignancy, but the same happens in infections as well. They also cause destructive lesions. The surrounding becomes and you can see any pus discharge. Look at the, it is so terrible, but there is pus discharge. This is got a special name of saber tibia. Bones frequently affected are nose, pelvic, skull, extremities, especially long tubercular bones such as tibia. Histology, occlusive histology, edema, that is present here. Granulation tissue containing numerous plasma cells and necrotic bone. We'll cover the pediatric disease later, but thank you very much for being patient listener.